Hey guys, I am live. All right, here we go. Adjusting the lighting because this is I'm not used to using the whoops. Yeah, I am so not used to using this particular light. Okay, anyways, I am here, guys. I'm going to go live on Instagram in about 15 seconds. There we go. Going live. And we're in business. Okay, so I am live on Instagram, YouTube, and Facebook. Let me get my chat box open here so I can see all the wonderful comments you guys are going to be throwing my way today. All right, guys, I am going to give you guys a minute or two to jump on board. Y'all didn't think like a little old hurricane was going to stop me? No, 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 no. We're going to keep this show and party going. And you guys, sorry, I'm like adjusting cameras and things like that because I'm using some different equipment tonight. All right, guys, I'm going to take a sip of my decaf. Cheers while I wait for you guys. Those of you who are watching my replay, please be sure to put replay in the comment section and give me a shout out. Send me your questions through there. I do go back and check after the show is closed to see who's been watching. And if you have any questions, I can pick up for you. All right, I see some of you popping on board. Y'all know the routine. You got to let me know who you are, where you're from, and what is in your drink this evening. So I don't know about you. My kids are off at a hurricane party because, that's what we do in Florida when a hurricane is coming. It's an excuse for us to have a get together or a party and eat junk food. Hey there, Harsh. What's going on, Pastor David? I appreciate those prayers for this hurricane, man. We got Emily coming in from Central PA with her lemon iced tea. She always brings the drinks. We got Ginny headed for early bedtime soon, but hope you have to stay safe in the storm. Me too. Me too. And I thank you for joining in, Jenny. I see we got Scott coming in from West Virginia with his cold water. Scott, I want an update. I'm holding you accountable. We got Pam coming in from New York. Thank you, Pam. I appreciate that. We got Harshes in Richmond with his water. We got Kimberly here with her protein smoothie. All right, we got some nice group jumping on board. And I got a special little talk for tonight. I've got a fun story to go with it, and we're going to have some learning going on tonight. So I actually have something prepared for tonight, and I don't have a sponsor. Wow, I know, right? This is what happens. Let's see. All right, let me just come on over to the Instagram channel. We got Abernathy on board. We got Jody Steins on board on Instagram. Hey there, Jody. We got Shellster on board. It's funny, I'm calling out Instagram handles because their names aren't on there. But guys, on Instagram channel, feel free to put the questions into the comment section. I'm having a hard time speaking this evening. Yeah, harsh. I like that meme that you put up there for me, Harsh. All right, guys. Yeah, so we got a Hurricane Helene coming on board, and people are so kind, sending messages saying, "Are you guys okay? You guys gonna do fine?" I'm just like, man, we're Florida. We got Florida man. We've got Florida man. We aren't afraid of a hurricane. All right, we got Earl from California with Orange Dream from Jamba. Man, he's getting fancy on me there. He's getting fancy. All right, guys, we're gonna say a cheers, and we're gonna get this morning started. Norma, welcome. Good to see you. All right, guys. So for those of you watching me for the first time and you're wondering who's this crazy lady talking about hurricanes, welcome. My name is Cosi Belloso. I'm a physical therapist, amputee specialist in Tampa, Florida, which is turning out to be quite the hurricane magnet. But thankfully, it's not going to be coming our way. We're just going to be getting all the wonderful bands and winds and mess and all that kind of fun stuff shortly. I'm actually looking out my window, and it is literally the calm before the storm. So I can see out my window, and everything is calm. We had a feeder band earlier, and we'll probably be getting some more this evening. Did I just say good morning? I probably did, Emily, because it's just been that kind of a week. So I'm going to share with y'all something I've been working on for the past, 3 months now. I think I've been working on this nonstop. So I've been very, very fortunate to have been invited to the University of Krakow in Poland. And I will be one of their keynote speakers at their limb loss symposium, which I'm really, really excited about. It's in October. I will be teaching a 6-hour continuing education course to their physical therapists there. And they are supposed to have a few people from a couple of different countries coming in to come to this limb loss symposium. It's quite the conference, and I'm really honored that they asked me to speak. But in the meantime, I have been eating, sleeping, breathing, drinking this presentation and preparing this 6-hour presentation that I have to give. Hey there, Tom, coming in. Thank you, Emily. But it's really wonderful, guys. Whenever I have the chance to teach a lecture, really pushes me out of my comfort zone. It's one thing when you're practicing, and I feel like at this point, after 23 years of working as a physical therapist, I can kind of do a lot of things with my eyes closed in the clinic. But, it's different when you're in a room full of your peers and having to articulate and teach these concepts, right? And it pushes you to really learn things from the bottom to be able to explain it. I don't know if it was Confucius or I don't know. Someone said something along the lines of, if you want to know if you really know something, explain it and teach it, right? So that's what we're doing right now. Hey there, Rob from Indiana with his raspberry lemonade. Harsh, man, you are busting out all the really cool little cartoon avatars. That's what they're called. I'm really loving the champagne one. That's awesome. So anyways, today, as I'm putting together this presentation today, I was putting together the part about how to teach a patient how to manage their limb volume and how to manage their socks and how to know their wearing schedule. So I was just like, you know what? Let's do that tonight for tonight's show. Does that sound okay, guys? Yeah, thumbs up. Kind of impromptu, kind of not. Glenn says, if I need an OI patient as a show and tell in Poland, I volunteer. I know, right? And yeah. That would be fun, wouldn't it, Glenn? That would be a lot of fun. No, yeah, that would be a lot of fun. Okay, so, and actually, Glenn, you're just going to be kind of twiddling your thumbs tonight because, you don't have a socket, so you don't got to worry about socks anymore, Mr. Show Off. But no, hope you can stick around either way. All right, guys, sorry, I keep forgetting to pop over to the Instagram channel, make sure people, if any questions are being asked. We got Joel on board, we got Jamie on board, Shelster, looks like they're still on board. All right, guys, so let's talk a little bit about, limb volume management. In the talk that I'm giving, I mentioned how it's probably one of the most frustrating aspects of learning how to use a prosthesis. Does anybody agree with me on this one? Like, hands up, Cosi poll. When you guys, especially those of you who have been using a prosthesis for a while, or if you're in the middle of learning how to use it right now, I find that with my own patients over the years, one of the most frustrating parts is learning how to manage. Sorry, I've got pop-ups coming in. Learning how to manage the limb volume fluctuations and knowing how to adjust the sock supply. Okay, it looks like everybody was just trying to send me pop-ups all of a sudden. Okay. Right. So, and teaching folks not only how to manage their socks, but how to manage limb volume. Okay. So does anybody have that experience? Frustrations? Yes, no, maybe so. Throw it into the comment section. All right. So guys, usually when I have my patients first come in and we're teaching them how to put on, hey there, Devon, and we're teaching them how to use socks and manage their limb volume, it's explaining why is it that the limb volume is changing so much, okay? So the first 1 to 2 years after an amputation, okay, the residual limb is going to be shrinking and expanding. And over the course of time, it's going to overall shrink. Like, that's what we want it to do. Now, the first 1 to 2 years, the reason why this happens is because of surgical inflammation. Number one, the first few months, surgical inflammation for sure. And yes, months for that to start to reside. Number two, the change in the shape of the limb. Right. And those of you who are experienced now, you probably remember wearing your shrinkers or in some cases your ACE wraps. Right. And the whole point of those shrinkers and ACE wraps was to help manage the volume and to manage the inflammation and also to help start shaping the residual limb and getting it ready for prosthesis. Right. And then the third thing that contributes to all of this is muscle atrophy. Right? Those muscles are cut, which means they're not going to function the way they used to function. And it's a use it or lose it scenario. So you're going to see atrophy beginning even in that first 1 to 2 years after amputation. Okay. After the first 2 years of amputation, different things are going to cause that volume change. Okay. You'll still have the process of atrophy, right? That's going to be something that's going to happen for the rest of your life. And our bodies are dynamic. Our bodies are not static. They don't stay the same. Okay. So even those of you who have really amazing limbs over the course of time, you're going to notice those changes, right? And then at the 1 or 2 year mark, it becomes more about focusing on what is medically causing the limb volume fluctuations. Okay, not that you shouldn't do that the first 2 years, but that's what the real focus is after a year or two, because after a year or two, that surgical inflammation should have gone away. The limb should be more or less kind of sort of remodeled. Okay, and it should start to stabilize. So if a patient is still experiencing some really dramatic limb volume fluctuations, then we know it's got to do more with the medical part of what's going on, And I always say the patient, when the leg or the foot is amputated, the diabetes is not amputated with it. The vascular disease is not amputated with it. Okay. Whatever underlying medical condition that may have contributed to the amputation is still going to be there. And it's still going to be trying to play havoc on your body if you're not getting it under control. Okay. So it's talking a lot to my patients about, okay, you're still having a lot of limb volume fluctuations. How's your glucose? How's your blood pressure? How's your salt intake? Right? What does your diet and nutrition look like? Some of you are going to be a lot more sensitive to that. What used to give you just some puffy fingers from eating too many salty chips now can result in a puffy limb that doesn't allow you to put your socket on in the morning, right? Those of you with autoimmune conditions that contribute to edema, for retaining water. Some of you folks who have lymphedema, history of lymphedema, right? All of these things are going to be contributing to this. And identifying what is the cause of the problem is going to help address it. Okay. Then after that, it's up to you. And it's not to say you can never have potato chips or you can never enjoy some of these things, but it's understanding if I do this or if I don't do this, it may result in my limb being a little more swollen the next day and having to compensate for that. Okay. And I feel like that kind of helps people understand. It takes a little bit of that frustration away when it comes to managing the limb volume and wearing socks and things like that. Okay. Emily says, yes, and lymphedema only adds to the frustration. Absolutely. Absolutely. Harsh, as far as where you can buy the most economical socks, I've actually, and this is laziness on my part, I've actually never really compared pricing before. I'm like I said, usually when my patients come to me, they already have their socks or their prosthetist issues them their socks. I know that's laziness on my part. I know there's this place called the Amputee Store. He puts out some really nice blogs and he runs, and I was actually just looking it up today. He does have a lot of socks for purchase available on his website. So you might want to just start by looking there. I also know that Amazon carries prosthetic socks, which is interesting. I was just like, wow, I did not expect Amazon to have amputee socks, but they do. And Emily says, still wearing a shrinker when not wearing the prosthesis. So let's just talk a little bit about wearing the shrinker, okay? So when it comes to managing the limb volume, right, you have ACE wraps, you have shrinkers, you have Tubigrip. So there's a few different devices that you can use to start doing. For me, shrinkers are my favorite. They're the easiest to put on. They give the most compression. So usually once your sutures or your staples come out, you're issued a shrinker and man, that really does the job really quickly. Okay. So if I have a patient who's having frustration with their limb volume fluctuation, that's one of the first things I'll ask them is, are you still wearing your shrinker at night? Okay. A lot of times folks can have what's called rebound edema, meaning you're wearing your leg throughout the whole day. You take your socket off and whoop, your leg puffs up again. Okay. And this can happen during the night. And then you're trying to like jump into your socket the next morning and you're not able to do that. And you're in a rush to get out the door and all mayhem breaks loose, right? So wearing the shrinker and then making sure that shrinker still fits, right? I've had some people that they like show me their shrinker and like I can practically see through it because it's so stretched out and worn out, okay? They need to be replaced. And if it doesn't take a little effort to put your shrinker on, chances are it's too stretched out, okay? Now, I've had some. And guys, this is not a shrinker, but I'm just going to use it for demonstration purposes. There are a lot of times where shrinkers might still have some really great stretch to them, but they're just a little too big on you because you've started to shrink. So a prosthetist, they have the best sewing machines. They have the most amazing industrial sewing machines in their prosthetic clinics. I like to sew on like my personal hobby. So I'm determined to have one of those sewing machines someday. But anyways, the prosthetist can sew a seam into that shrinker, right, to adjust it for you, because if it's still in good shape, why throw it out and get a new one and pay for a new one? Okay, so that's one hack right there. Okay, so management of, but at the end of the day, guys, the best way to manage your limb volume is to manage what is causing the limb volume, the fluctuation. Okay, there's no shortcuts around that. All right, Dan says 1 year into amputation, constantly experimenting with socks. Yes. Yes, and this is frustrating. Tatiana, ¿cómo está? I'm glad to see you here. Oh, it's Andre on Tatiana's account. Hey there, Andre. How are you? I've been conversing with your lovely wife for the past few weeks, so it's nice to see you on board as well. Roll, we're going to get to your question in just a minute. Emily says that she's seeing a dietitian at the beginning of October. And guys, again, we're human. We have our moments of weakness where we do things that cause our limbs to puff up. Usually it involves what goes into our mouth, right? Nutrition and hydration, right? And again, it's a decision that you have to make. And I tell this to my patients all the time. I can give you all the information, all the good information, all the right advice, but you're the one who has to make that decision, okay? So at the very least, knowing what is causing the limb volume fluctuations can help. Okay, so when it comes to seeing a patient for the first time in my clinic, okay, I like to joke around that what happens in the prosthetist clinic on Friday afternoon is not what's going to happen at the physical therapist clinic on Monday morning, okay? So if I have a patient who comes in, they're like, hey, I just got this new socket. I was in the prosthetist office the other day. I'll ask them, okay, about how many socks did your prosthetist put on, right? And they'll say, it was about 6-ply socks. Ooh, let me get my socks. I actually have socks. Here they are. Okay. I actually have socks. Ha ha ha. When I was at Ronnie Dixon's clinic in Tennessee giving a course a few weeks ago, I actually, you guys know how I joke around and I say every prosthetist has a dusty closet somewhere that has old prosthetic stuff. Well, whenever I go to a prosthetist clinic, I head for that closet and I just raid their closet. And I'm like, do you need this? Are you using this? So I scored a nice little sleeve that nobody's going to use anymore. And I make sure, I really make sure nobody can make use of this stuff because I don't want to take away from somebody else, right? And then they gave me some socks, which I washed. So they are all ready for demonstration because I never have socks for demonstration. So I'm so glad I have some right now. All right. So we have what looks like a 3-ply, a 5-ply, and this feels like a 1-ply. Okay. So these are black socks. They come in black, they come in white. And you can see this one's labeled quite nicely. It's got a number 3 on it. This one has a number 5 on it, and you can see that they have different colors. So this particular brand name, the yellow is the 3, the green is the 5, right? And then the 1-ply doesn't really have anything on it. It's just plain black. It doesn't even have a seam up top, but I can already feel that it's thinner, okay? So when we talk about amputee socks, okay, and we talk about adding socks, we're talking about ply. We're talking about the thickness of each sock. Okay, so this is your baseline. This is 1-ply. Okay, this one that has 3 on it is 3 times as thick as this 1-ply. This 5, sorry, I keep putting in the wrong part of the camera. This 5-ply is 5 times as thick as this 1-ply. Okay, so for example, if my patient is wearing 3-ply socks, it means that they're wearing 3 of these, one layered on top of the other. Okay. When they get to wearing 5-ply, they can wear 5 of these, one layered on top of the other, or they can just get a 5-ply sock, which makes it a little bit easier. They just have to pull one sock on. Okay. And then they can add accordingly. All right. So if my patient comes in, they're like, yeah, my prosthetist said I need to wear 6-ply sock, then usually what it means is that they're wearing a 5-ply plus a 1-ply sock. Right? So I'll say, okay, let's go by what the prosthetist started you off with, right? So I will apply everything for them. There's a saying in healthcare, it says, watch one, do one, teach one, right? It's one of those really old sayings that they used to say to the doctors in training and they still say it, okay? And it's basically, this is how you learn in medicine. This is how you learn in healthcare. You watch someone doing the procedure, you try to do it yourself, and then you teach someone else the procedure. And that's exactly what I do when it comes to donning and doffing the legs, the prosthetic legs. So even if my patient's already been to their prosthetist office and they're like, yeah, my prosthetist taught me how to put on the leg. I say, okay, let me show you how I do it. And let's walk you through the whole process. So I will put everything on for them. I'll put on the liner, the socket, tighten up the lanyard, do the clicky knob, do the valve, whatever it is that needs to happen to get that leg put on. Awesome. And then I take everything off and I have my patient do it. And then they take everything off and then they talk me through how to do it. And that's how I know that people are actually understanding all the little nuances of putting a leg on. And this includes how to make sure your liner is not rotated, how to make sure that you're unfolding it all the way and putting it on properly and getting full contact. So as you can tell, I'm a real stickler when it comes to these details because all of this will contribute to helping manage your limb volume and to helping you troubleshoot when something is not going right. I find that when people skip these steps and they don't learn these little details, that when something isn't going right for them, they're not sure where to start or what to look for. Right. Also, if you follow all these little meticulous steps and details, you're less likely to make a mistake and get a better fit for your socket. Is all this making sense, guys? I know I'm real picky. Yeah, Tom says after taking a warm shower, my limb can be a little swollen and hard to get back into my prosthetic. Yeah, because the warm shower gives that vasodilation. It opens everything up and you get a little more fluid in there. Emily says I've used tuba grip too. Compadre. Oh man, good to see you, man. All right, we got Chuck on board as well. Let's see. Devon says if you have medical insurance, you should be requesting shrinkers once or twice per year through your PCP and take and fax the referral to your prosthetist. Yep. Yep. Let's see. Emily says, I've had lymphedema for years, even before amputation, and it's only been suggested now that I see a specialist who deals with lymphedema. What? They suggested seeing a vascular doctor. Yeah, no, Emily, that for sure. And I'm surprised it's taken this long for someone to recommend a specialist for you. Hey, Ashley from Tennessee, girl, you got to watch your back because, Hurricane Helene thinks she's going to party here in the Florida and, head up to Nashville. So you got to watch your back there. Hey there, Ronnie, good to see you. Royal Knit, he says, is his favorite sock manufacturer. Yeah. Is that what this is? Yep, Royal Knit, RK. They feel good. Actually, I put them through the washer and dryer, which you're not supposed to do, guys. You're not supposed to do that. I only did it because, again, it came out of somebody's dusty closet and I don't know, something going on with these socks. So I just gave them a good washing and drying. But yeah, they held up really well considering they did go through the dryer. Let's see. Hang on, Ashley. I'm going to get to your random question. I promise, darling. Okay. So you put the socket on, everything is on. Okay. As a PT, I'm checking for landmarks. In my below the knee amputee, I'm looking to see their kneecap. Where's that patella? Okay. It shouldn't be all the way down in the socket. It shouldn't be all the way up. It should be somewhere in the middle. And I'm teaching my patients these things, guys. Okay. For me, I consider it a success when my patient knows their body better than I do. And when they can troubleshoot how their socket fits better than I do. They should. By the end of treatments, they should know more than I do about how to troubleshoot the fit on their leg. Okay. So I teach them, okay, there's certain landmarks here and we try to, get the right fit there. Okay. Once I feel like the right fit is present, I tell my patients, stand up and get a mental image of what this feels like. I know it sounds weird. Okay. But it should feel a certain way. Right? It shouldn't be painful. It should feel like there's a really snug glove around the residual limb. They might feel some pressure, even maybe a little bit of discomfort, but no pain. Okay. And I tell my patients, okay, everything is looking good. This is what it should feel like. And then we start the clock. Actually, we start the clock the minute the liner goes on. And this is something that my mentor taught me. And if you think I'm a stickler, holy smokes, my mentor was like this 5'7" terror. He was like with a stopwatch, not kidding. So the minute the liner comes on, he would start that stopwatch for 5 minutes. Why? Because liner on the skin is something that is contacting the skin. And the whole time when it comes to adjusting socks, when it comes to wearing schedules, it's allowing the skin to have time to get used to wearing something. So it starts when the liner goes on. Okay, so we're 5 minutes in. So we've been doing a little weight shifting, maybe even taking a few steps in the parallel bars. Then I sit my patient down and I have them take everything off. And yes, it's a total pain sometimes because just to get into the socket is a lot of effort, right? So I have my patients take everything off and I have them look at their skin. I have them look at the front, the back, the sides, the bottom of the residual limb. And I forgot one step, guys. Before, and this is something I teach my PT students and my younger PTs, before I put anything on the patient, I look at the patient's skin. Okay. People who are really, really fair skinned, it's really easy to see stuff, right? Again, you look at them the wrong way and their skin gets pink and red and whatever. Okay. People with darker complexion, you also have to look. Okay. Are we seeing discolorations? Are we seeing changes in the complexion? Right? Because someone who has darker skin is going to look different if they have a pressure point than someone who has fair skin. Okay. So I always like to take a look at the skin and see what does it look like before I put everything on so that I know what's different. All right. So, patient sitting down, we take everything off, we look at the skin. Okay. I'm going to call up a picture. I'm going to share the screen for a minute. Let me make sure I do this right. And we're going to start off with our below the knee. Okay. So, I'm going to show you. Oh, there it is. Okay. Here we go. All right, hopefully you guys can see that. And this is just a really nice picture. You'll find this picture, guys, pretty much in every like prosthetist, physical therapist textbook, right? We have your pressure sensitive areas and our pressure tolerant areas. And as the name indicates, pressure tolerant is where you're supposed to have some pressure. This is where the socket is built in a way so that your body weight is distributed through these areas. So what does that mean? It means that when you take your socket off, okay, you might have some pinkness here, right under your kneecap. You might have some pinkness here, okay, on the outer and the inner edges of your residual limb. And this is the backside right here, where we're looking at right here, where it says popliteal fossa, okay, that's the back of your leg. So you should be having probably some pinkness and redness here, okay? Where you should not have pinkness and redness, or at least not a lot of it, is in these areas over here under the pressure sensitive areas. Okay. So in the front part of the leg, the outer edges here of your kneecap. Okay. This part right here, especially right down the middle, that's your shin bone right there. And you can see it's all nice and narrow and the end of the shin bone. That's a big one right there for our below the knee amputee friends. Okay. And then right here, this little spot right here, that's your fibula. That's the tiny little bone on the outside. And then here's the end of that tiny bone. We do not want to see redness in these areas. We call them hot spots. Okay. And then in the back of the leg, right here, where your little hamstring tendons are right there, we really don't want to see the redness back there either. Okay. Let me see if I can go back to you guys. Did I do that right? Okay. Can you guys give me a thumbs up? Did you guys see that picture clearly? Did it come out like big enough where you could see it? Yes, no, maybe so. I know it takes like a minute for like answers to come in. So I'm always sitting here. I feel like I need to have the Jeopardy theme song playing while I wait for people to answer the questions I ask. Oh, hey, it's Jammy from Arizona, drinking vanilla hazelnut coffee on Instagram. Hey there. And we got Luis Mora on board. You think you could sneak on board? I didn't see you. We got Dave on board there as well, and Leanna and Catherine. Awesome. Okay. So, yes, good question about the very bottom. Okay. So, Andre, when it comes to the bottom of the residual limb, some people call it the residual stump, it should have contact, but not pressure. Okay. Because some people might say that and go, wait a second. You are seeing pressure that it can have pressure there. No. It can have contact, but not pressure. And Devin, you said it beautifully. In layman's terms, you want pressure on the soft areas and the muscle. Very nicely said, Devon. And guys, when I'm working with a patient, I don't tell them, oh, the tibial tubercle, no. I say here, and here, we are allowed to see some pinkness and redness. Here, and here, we do not want to see any pinkness or redness. Okay. So here's what happens. Patient will take off their, the liner, the socket, everything else, and we're going to see some pinkness there. Okay. We might actually see some pinkness in the areas we're not supposed to see pinkness and maybe even a spot of red. Do we freak out? No, we don't freak out. We sit and we watch. Okay. And we'll watch for about 5, maybe even 10 minutes. If I see that the redness is starting to subside, then we know we're on the right track. If there's redness in the areas that it's not supposed to be, then I might add a sock. Okay, so I'll add one ply at a time. Or if I feel like, I think I may have put in too many socks, I'll take away one ply sock at a time. Okay. And this is where it's like 80% science, or excuse me, 20% science, 80% feel. Okay. So even for the physical therapist and for the prosthetist, you have to do some troubleshooting to see how it's working. Okay. So when we do Devon, who is Devon? It's not Devon. Is that you, Ben Gregory? I think it's Ben Gregory. Okay, sorry. I got like distracted there by somebody who was writing me. What are my thoughts on the half ply socks? I haven't seen them in a long time, but I like them. Way back when dinosaurs roamed the earth and I started practicing as a physical therapist, we had what were called sheaths, and they were super, super, super thin. They felt like pantyhose material. Like they were very, very thin, and they were considered to be half ply. I'll be honest, I haven't seen anyone with that in a long time. Oh, it's Damon. Oh my gosh, Damon, dude. Yes, and we need to go running once, like, the flooding on Bayshore calms down, because we're going to get a lot of flooding there in our running route. Holy cow, Damon. It's been a minute. Oh, actually, I'm gonna be at West Coast next week. Okay. Anyways, back to the sock thing. I actually do like the half ply socks. I think it gives you just a little bit more wiggle room, because sometimes, I mean, even though this is only a one ply, here you can see it's still a thick wool sock. Okay. So it could be that adding a ply is just too much, but you need, maybe a half ply. Okay. So we'll do 5 minutes at a time. If I have somebody who has really sensitive skin, then I'm pretty strict about sticking to the 5 minute rule. And I do time it, guys. And I teach my patients how to time it. Why? Because if they get a blister, it's game over. Okay. And if it's frustrating trying to manage sock volume, it's even more frustrating when you get a blister and you have to basically get benched for a week or two to wait for that blister to heal. And that to me is like, no, I don't want to do it. Has it happened? Does it happen occasionally? Yeah, it does happen. But in the 23 years I've been practicing in my clinic in front of me, I can probably count the number like twice where it actually happened, where the blister actually formed during the treatment session itself. Okay. Cause no. Okay. So if a patient has a lot of sensitivity on their skin, meaning that even though we know we have a good socket fit and we've got the right amount of socks, they're pinking up every 5 minutes, then every 5 minutes they need to sit down, take everything off, and let that pinkness resolve. Okay. And yes, they need to take it all off. Okay. Just sitting down is not going to take the pressures off. And I know that sounds really strict, but it's true. Okay. And I've had some patients that, again, they have come in with, after working with on their own and trying to figure it out on their own, and their skin is full of blisters, and their prosthetist has said the socket fits fine. And it's really because they're being too aggressive with their wearing schedule. It might take time. And sometimes it's that. Sometimes the skin is what's holding the person back from getting back to their mobility. They might actually have great strength. They might actually be walking pretty decently. It's the skin that's working against us. And it's not to say that there's not a solution. It just means you need to be patient and wait. Okay. Mhm. Kimberly says, person turquoise waving. What does that mean? What am I missing there with that, Kimberly? Um, Emily says, I get pink in certain spots, but the color returns to normal after a few minutes. And that's normal. That's kind of the way it should happen. And again, guys, you guys are going to know your bodies better than the prosthetist or the physical therapist. Okay. And there are some people that even after years of using a prosthesis, they still have little pink spots that show up in the areas that they're supposed to show up. Okay. And then as we're doing all of this troubleshooting, I'm also asking questions like, okay, you keep getting a red spot right here. And even though we've changed the socks, even though we've adjusted the socks, you still keep getting a red spot here. Are you feeling pressure? Is it painful? Do you feel like there's something rubbing in there? Okay. And little by little, you start troubleshooting all of these things. Okay. Because what you don't want is for your patient to go home, for them to have redness, pain, and they're not knowing where it's coming from. Okay. And it used to be, y'all think I'm real strict. It used to be the first place I worked at Jackson Memorial Hospital. We did not let patients take their legs home until they could demonstrate how to don and doff it properly, how to explain all the parts of the prosthesis, nothing fancy, but just understand the basic parts, and how to explain the protocol for the wearing schedule. Like, that's how strict we were back then. And it worked great because it meant that our patients had less skin breakdown, and that when it came time to taking their leg home and practicing at home, they were more confident, right? Because we had given them all that information. All right. Yes, actually, Harsh, I can probably do an e-blast and share that picture. And actually, guys, let me share the picture of the one with the above the knee amputee. I did find one, a good one. I'm still looking for like the one I really, really like. Here we go. And this one is courtesy of a website called Physiopedia. I do want to give them a shout out because they've got some really great pictures. Okay, so guys, anterior view means you're looking at it from the front. Lateral view means you're looking at it from the side, okay? So it's really easy. The red areas are the areas that are pressure sensitive, meaning we do not want to see pressure in those areas. Okay, so this is the bone that sticks out right in front of your hip. Like when you put your hands on your hips, this number 3 right here, that's one, and that one can be a bit of a bother right there sometimes. On the side, this is called your greater trochanter right here. It's like a little bony, the hip dip, right? Where women talk about having hip dips. That's right there. That's that spot right there. And then, ooh, that was good. Okay, now we can see it better. All right, and then obviously the area here in the groin area, that's a pressure sensitive area, meaning we don't want to have a lot of pressure in this area. You'll notice that right next to it, right here, this green spot is a pressure tolerant area. That's your sits bone, where when you sit down, that's the little bone in your bottom right there. That one is supposed to carry the weight, okay? And then like Damon said, all the areas that are soft, so all this fleshy thigh tissue right here can carry the weight. And you'll see that on the bottom, it's labeled as green, meaning it can have contact with the socket, not necessarily pressure. And then obviously at the end of the bone, we do not want to see pressure. We don't want pressure at the end of the bone. Hang on, let me see if I can get back to you guys. There we go. Okay. Was that good? Did you guys like that picture? Did that make sense? But I like the way Damon said it. Basically, if it's soft and fleshy, it can take and hold the pressure. And the body weight is distributed throughout all of that area. Here's a really interesting thing. A lot of people, doctors included, don't understand that the bottom of the limb should not be taking weight. And this is interesting because sometimes I'll be talking with a doctor who's seeing an amputee, and they may not necessarily have a lot of amputees in their care. And they'll say, well, they're putting weight into their prosthesis at the end of their limb, so they can just keep putting weight through there. And it's like, no. The weight is not supposed to go through the end of the limb. The weight is distributed throughout the limb. Okay. And certain sockets will put pressure on certain areas more than others. Okay. And that's a whole nother talk that we can get into later, depending on the shape of the socket. Okay. Let's see. Harsh says I only used on temp socket back in Y2K time. Dave, when am I coming to Rehoboth? I don't know. Actually, in Maryland, it's actually my family's coming down for Thanksgiving this year. We're not going to, which is too bad because I haven't been to Rehoboth in a while. It'd be nice to go to the beach there and to see what's going on. Let's see. So Marianne says, I have 3 socks that feel like t-shirt material. And that's another thing I do want to bring up, guys. Different brand names, okay? You're going to have wool. Typically, I think the better ones are the wool, right? The more natural fiber for me is what I prefer just because it breathes better. That's just my personal preference. When it comes to the socks, even though all the brand names, you'll have 1 ply, 3 ply, 5 ply, and I think there's one that has like a 7 ply. That's pretty standard across the different brand names, but 1 ply in one brand name might be just a little bit thinner or a little bit thicker than the 1 ply of another brand name, right? They're not going to be exactly the same. And those of you who have been wearing sockets for a while, you can appreciate the differences between 1 ply of one brand and 1 ply of another brand. But for some folks who are newer amputees, that might be throwing them off, and they may not understand, like, well, wait a second, I'm mixing matching socks, but, I have the same ply on. Why doesn't it fit the same? And the other thing to also keep in mind is that over time, these will stretch, right? So what was once a nice, plush, thick 5-ply over the course of time might become a 4.5 ply, right? So some people are just like, well, I know I wear 6-ply every day. Why isn't it working? It's like, no, 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 no. You got to think about it as this is what it's supposed to feel like. Okay. And how many sock ply you wore the day before is just kind of a ballpark to start with. Okay. It's how it feels on your leg. That's what you should be going with. Okay. And again, sorry, this question came in. I'm like, whoop. Let's see, Dan says, I'm an AK. When my femur bone would clack on the side of the socket, my prosthetist would put pads between the socket and the soft liner in certain areas. Yeah. And that's just to kind of help get the bony lock in the socket. Okay. So when you have, this is an above knee socket. Okay. It's actually yes, I'm holding it the right way. It's a right-sided above knee socket. Okay. So when you have your femur that's cut, it's kind of fishtailing around, for lack of a better word, right? It doesn't have that lower leg to anchor it in place. So part of what the socket needs to do is it has to try to hold that femur in place in the position angled in a little bit the way it used to be. Okay. So if you're getting pressure on the lower outside part of your femur, which that's a very common one for our above the knee amputee friends. Okay. That means that there is not a good enough bony lock, and your prosthetist might need to make some adjustments there. Another part that contributes to that, Dan, is glute strengthening. Okay. Somebody who has a lot of glute weakness, that glute muscle is not securing and stabilizing that femur bone. Okay. So that also needs to be taken into account. Which brand? Harsh, like I said, I'll be super honest with you. I have not researched the sock brands. I do recognize this one. I think the Royal King, I think is what Ronnie said it's called. It's labeled with RK. And it's just by the feel of it, I can tell it's a pretty decent quality sock. Let's see. What would help instead of changing sock ply is this, the Click Medical socket, the adjustable socket. Okay, so this is something that I've really come to appreciate in the last few years after especially getting to know this company a lot. They've been sponsoring the show now for 3 years. I absolutely love their adjustability on their socket. It can adjust up to 10 ply. Okay, so think about it. That would be the equivalent of 2 of these socks, 2 of these 5-ply socks. Okay, it gets pretty thick. And again, I'm in Florida, so things are always hot and humid and sticky here. So if a patient can avoid having to wear 10 ply of these, that's kind of a big deal. That's kind of a big deal. Okay. And also what I really love about the Click Medical, remember how I told you guys that sometimes when you're adjusting socks, you can only adjust like 1 ply at a time, and that might not be fine-tuned enough. When it comes to these, you can adjust it. It's like they call it micro adjustments. So you just twist ever so little bit, and that just kind of does that last little bit of tightening or last little tiny bit of loosening. So it's a much more fine-tuned adjustment, in my opinion, when it comes to the adjustable socket technologies like the Click Medical Revo Fit. Let's see. Patricia says, hi, I have a guillotine cut. Wow. No staples or stitches, just healed on its own. I have not heard about that in a very long time. That's I'm sure there's a pretty incredible story on that one. Kimberly says my phone must be possessed. That, or you have the same gremlin living in your phone that I have in my computer sometimes, Kimberly. See, Pedro says I'm 3 weeks in my first socket and prosthetic leg. The end of my residual limb is very sore. I'm scared to stop wearing my leg. Should I be taking breaks? Skin ID, great. Yes, Pedro, you should definitely be taking breaks. Okay, so let's get back to that wearing schedule that I was talking about earlier. And Pedro, this is something that your physical therapist and your prosthetist should be working with you to help you with this, because you're not supposed to have a sore residual limb. It might be a little uncomfortable, right? But it shouldn't be to the point where you're saying it's sore or painful. Not at all. Okay. So yeah, a lot of times I'll have folks come in and they're very aggressive with their wearing schedule, because they're excited, right? They finally got their prosthetic leg. They want to start wearing it. They want to, get as much experience in it, but that can work against you. Okay. As we're seeing, maybe with Pedro here. Okay. So when you wear it for those first 5 minutes, you've established what's a good feel for socks. Okay. I'll usually tell my patients 5 minutes at a time, 2 to 3 times a day. Okay. 2 to 3 times a day. And I tell them, you've got to let your limb rest in between. Okay. When it means rest, it means everything comes off. You might need to put your shrinker back on to prevent that rebound edema that we talked about earlier. Okay. But your limb should be resting. If they come back in, everything was tranquilo and tropical, as we say in Spanish, everything was good. There were no issues with it. Then usually what I'll do is I'll increase it by 10 minutes. And again, depending on the skin, if I have somebody who looks like they've got really great skin and it's very tolerant, then maybe I'll say, okay, let's go to 15 minutes 3 times a day. Okay. I don't jump it to a half hour or an hour or whatever. We jump it and then we have increments throughout the day. Okay. It takes a little bit of time, but to me, it's worth it in the end because we very rarely get a blister when we follow the directions that way. Okay. And it allows the skin time to get used to wearing a leg without having pain, without having this soreness. Okay. Notice I don't say that the skin toughens up. Okay. A lot of people think that if you wear a prosthesis, that having a callus is a very normal thing, or that's what's supposed to happen. That is not the case. Okay. And again, when we have a callus, when we have a blister, okay, it's a sign that there is something going on, whether the limb is getting too much pressure, there's too much shearing, there's too much friction, something is going on. In my newer amputees, if I see a callus, usually it's because they're a little aggressive with their wearing schedule and they're wearing the leg just a little too much and they need to back off. And also looking to see if the liner is being put on properly, if they have enough socks, if they have too many socks, right? Looking at all of these things together. Make sense? Oh, okay. So you were able to see the picture, but not necessarily the mouth. Got it. Okay. Yes, Harsh, it does depend on the yarn count used in socks. And again, guys, I've gotten a little bit lazy over the years when it comes to socks because usually my patients, they just bring in a bag of socks and I just work through them and we work with what we've got. Mm. Ashley says that happened when my prosthetic company changed companies with their shrinkers. I didn't like thickness of the new shrinkers. They still order you the old ones. I know. You get used to the good stuff. Um, Okay, so Pedro says your skin is great, but your soreness. So, in that case, Pedro, it might mean that you're wearing the leg a little too much. It also might mean that you are bottoming out in your prosthesis. So again, where's my BK? Okay. Bottoming out means when the bottom of your residual limb is hitting the bottom of your socket. So, as I mentioned earlier, the bottom of your residual limb might have contact, right? It'll have contact, but it shouldn't have any pressure going through the end of the residual limb. Okay. So, that's something else to consider. It could mean that you might need to have an extra sock to help lift you up out of that socket just a little bit so you're not bottoming out. Mhm. Eric says, I make my liner a little thicker. Well, now that you can make your own liners there, Eric, props to you. Ashley says, my prosthetist suggested an hour on, an hour off, which sucks as a teacher, but it works even 7 years later when I get a new socket. Yeah. Yeah. And guys, prosthetists and PTs, those of us who work with amputees, we all have slightly different wearing protocols. I tend to be a lot more strict with mine, just again, because maybe that's how I was just taught. And my mentor was even 10 times more strict than I am. But some clinicians are comfortable telling their patients, go ahead, wear it for an hour on, hour off, hour on, hour off. For my newer amputees, I find that it's a little bit aggressive, and I find that patients sometimes get a little sore from that. But again, whatever the case is, you need to be communicating with your prosthetist and your physical therapist about how to wear it and how often and how it's the feedback about how it's feeling. So Emily says we worked in half-hour increments. Marianne says, Chad, my prosthetist, gave me a distal cup, which definitely helped where my socket rubbed. My pleasure, Pedro. Hey, Beth. Yes, better late than never. I'm happy to see you. Okay, there was a question back here. Let me see if I can find it again. Ashley says, my random question. I had a labrum repair 8 weeks ago because I've fallen several times over the last few years and throw my arm out. Oh, Ashley. Is this common amongst amputee or am I an anomaly? It's common among the human population as we're aging. So the labrum is this cartilage that lines your shoulder joint and also lines your hip joint. So you have your shoulder or glenoid labrum, and then you have your hip acetabular labrum, right? So what happens is that cartilage is like kind of almost fused to the socket joint. Let me see if I can find. Come here, Bob. Yeah, you don't have much of a labrum there anymore, do you, Bob? I guess you've been falling down too. Right. So here's what happens. All right. We have our shoulder joint like this, and then, sorry, Bob. So you have your shoulder joint, and then your little shoulder goes in there and moves the ball. So this is called the ball of the humerus, the head of the humerus, ball and socket joint, right? So the labrum is like a cartilage. Oh, shoot. I don't have any battery left, and I don't know where my charger is. So we're going to have to make this quick. Yeesh. Whoops. Okay, so labrum's over here, right? Protects the joint. Tear in the labrum, no good. And you usually have to get a lot of that repaired, surgically repaired, because there's not a whole lot of circulation there. So they need to repair it to make sure that there's not arthritis down the line. Okay, so falling as an amputee, yeah, unfortunately, it is common. I don't like it, but it does happen, right? It's going to happen at some point in your life as an amputee. You will experience a fall. Hopefully, you will not injure anything in that process, but it does happen. And then, yes, having to have that labrum repaired is something you need to do. Because again, Ashley, you're young, you're very active, and labral tears, some labral tears, like very, very tiny ones, can repair on their own, heal up on their own, but it tends to progress to arthritis down the line, and in some severe cases requires a joint replacement. So usually when I see that people have labral tears, I'm like, yeah, go get yourself to an orthopedic surgeon and really see if you need to get that repaired or not. So good thing you had it done. Okay, I think there was one more question in here, but I think that's it. And she says, even though I'm in PT for my shoulder, my PT will analyze my gait every time I go in and let me know if I'm walking funny. Well, good. That means you have a good PT. Your patient isn't just your arm. Your patient is from head to prosthetic toe. Okay. Guys, I think I've covered every question, and my battery is literally about to give up the ghost on this computer. So with that being said, guys, I am going to say good evening. If you have the chance, please share this video out to your social media groups or to your own Facebook page or Instagram page if you can do so, or on your Instagram story. And that's about it for this evening. All right, guys. Give me a thumbs up, hit like on this post if you guys enjoyed the talk for this evening, and don't forget to send me your questions through my email. You can always email me directly, cosi@cositalks.com. All right, guys, those of you out there in the path of the hurricane, stay safe, stay dry, and hopefully we will see you next week, same bad times.